So good afternoon, everyone. I think we will make a start. And welcome to the Oak Room at County Buildings in Staffordshire and the Staffordshire Health and Wellbeing Board today on Thursday, the 7th of March. Now, before I start, can I say what a fabulous turnout. And let's hope it continues like this. So there's quite a few new faces, different faces around the room. So before I formally start, we'll go around the room and introduce ourselves to each and everyone. And can I just remind you that this is meeting's being recorded and is being streamed live. So I'm Mark Sutton. I'm Staffordshire Cabinet Member for Children and Young People, and I chair the Health and Wellbeing Board. And on my left is...
Yeah, good afternoon, everybody. Councillor Mike Wilcox, newly appointed Cabinet Member for Health and Care.
Hi everyone, I'm Tilly Flanagan. I'm here representing the Ageing Well priority. I work for Staffordshire County Council as part of the Public Health team.
Hi, I'm Vicky Rowley. I'm a Commissioning Manager in the Public Health team as well at Staffordshire County Council.
Hi, I'm Suki Johal. I'm a GP in Codsall and I am a place clinical lead for the south of the ICB, and I'm also the chair for the Frailty Clinical Improvement Group.
Hello everyone, I'm Chris Bird. I'm the Chief Transformation Officer at Staffordshire and Stoke-on-Trent ICB, and I'm one of the ICB's representatives onto the board.
Hi, I'm Rachel Gallio. I'm a Deputy Chief Medical Officer for the ICB.
Hi everyone, I am Nisha Gupta, Assistant Director for Children's Social Care in Staffordshire County Council and standing in for Neelam today.
Hi, Councillor Jill Heason, Newcastle Borough Council, Cabinet Member with Portfolio for Community Safety and Wellbeing.
Rita Heseltine, South Staffordshire District Council, Portfolio Holder at Cabinet Level for Regulatory Services.
Good afternoon, Andy O'Brien, Chief Executive, East Staffordshire Borough Council. I'm standing in for Tim Clegg of Stafford Borough Council.
Afternoon everyone, Phil Pusey, Chief Exec of Staffordshire Council of Voluntary Youth Services.
I'm Dave Bassett, Engagement Officer for South East Staffs for Health Watch, here with Baz to do the presentation from Health Watch.
Yeah, my name's Baz Tamis, I'm the Manager for Health Watch Staffordshire.
Gary Jones, Chief Exec at Support Staffordshire.
Chief Superintendent Emily Clark. I've changed my name since the last time I was here, and I'm the Chief Superintendent for Staffordshire Police for the county.
Hi, I'm Ian Reid, Staffordshire Fire and Rescue Service Head of Prevention, Protection and Partnerships.
Richard Harling, Director of Health and Care for the County Council.
Hi, Claire McIver, Assistant Director of Public Health and Prevention at the County Council.
John Topham, I'm a Senior Commission Manager in Health and Care, and I also kind of do a lot of the kind of legwork administration for this board.
Jennifer Norman, Member and Democratic Services Officer.
Good afternoon everyone, I'm Liam Archer, I'm a Democracy and Governance Officer for the Council.
Okay, thank you everyone. So we move on to the agenda proper, item 1. Apologies, any further apologies?
Thank you, Chair. No further apologies other than Neelam and Tim. Thank you.
Lovely. And does any member of the board have any declarations of interest? Okay, thank you. Minutes of the previous meeting have been circulated. Can I take those as an accurate record of that meeting and subsequently sign them? Does anybody have any comments on any alterations? No? Okay, I'll take that as read. Liam, do we have any questions from members of the public that have been submitted?
Thank you, Chair. I've had no questions submitted.
Okay, thank you for that. In which case, we'll move on to item 2, which is Health in Ageing Priority and a progress update. And it's over to you, Tilly.
Okay, everyone. We're here today to give you an update around the Healthy Ageing priority, which is one of the 4 priorities for the Health and Wellbeing Board. It's been a year since the last update, and it's probably fair to say from the Healthy Ageing priority, it's probably one of the newer priorities. So we are playing a little bit of catch-up compared to some of the other areas of work. However, having said that, I think this year have made quite considerable progress, and Vicky will sort of talk you through some of the work and some of the progress that we've made. I think it's probably worth also sort of saying is that this board sponsor for this work is Richard Harling, and from Health, it's actually Rachel Gallio. So we do feel we've got the great and the good sort of supporting us in this agenda. And we also work very closely with Zafar Iqbal, who's an MPFT and linked to some of the work that Suki and Rachel are involved in as well. So we've tried to take a very pragmatic approach to this work. It's not, while the focus is for the Health and Wellbeing Board, we've always developed this work alongside our colleagues within the ICB. So it's sort of one plan in terms of healthy ageing that works across the work streams. And as Vicky sort of takes you through this work, you'll hear that demonstrated. So in terms of what have we done so far, it's worth saying that since we last met, we've now got a healthy ageing partnership, which is actually sort of moving from strength to strength, and that partnership has developed from 2 stakeholder events that were held last year. We had an external speaker, well known in this agenda, Dr. Muir Gray, come and speak to us, very enthusiastic, and we took home some real sort of some really sort of positive messages that helped us, and I think it did sort of gain some enthusiasm and interest in this agenda. So they were very well attended events. We've also now got we've co-designed with partners, a range of partners, a draft plan, which Vicky will sort of talk you through, and that does identify some particular actions that we want to take forward for the future. So the reason why we have come today is obviously to give you an update of the work so far, but we also would like to seek some feedback from yourselves as a board in terms of the commitment to this agenda, and also some of the delivery in terms of the future. So I'm going to hand over to Vicky, because Vicky can take you through a little bit more of the detailed work.
Thank you, Tilly. A paper has already been shared with members of the board that outlines the work that we've done so far. It covers off the reason why we're doing this, which is ultimately to improve healthy life expectancy for our population in Staffordshire. And the objective was that we identify how we can develop a shared healthy ageing plan that represents the priorities for the Health and Wellbeing Board, as well as the Staffordshire and Stoke-on-Trent integrated care system. And as Tilly's mentioned, we've tried to do this in a way that's as collaborative as possible. We hosted those 2 events earlier on in 2023 so that we could really understand from a variety of different stakeholders what it is that we need to do in order to achieve that aim of healthy life expectancy, and to understand what are the outcomes that people want to achieve when it comes to healthy ageing and ageing well. And it's the outcomes within the plan, the draft plan that we shared with you as well, that have really kind of framed the activities and the objectives that we've identified with our partners, so that we can build this plan that achieves those outcomes, but also in a really measurable way. We've done that through the Healthy Ageing Partnership, which has provided that infrastructure and leadership, but in order to identify the detail, we then established a Healthy Ageing Task and Finish group, which again was as representative as possible across the system, to bring partners together and actually identify what is it that we're already doing. And that group demonstrated that there is such a great deal of activity already happening across Staffordshire, which is achieving ageing well for individuals and for our communities. And the plan that's been shared with you tries to display that sentiment that we're not starting from a blank piece of paper. We recognise that so much activity is already happening. Things are happening currently, there are things that are in the pipeline for the future, and then there are elements that we feel as though are ambitions that we want to achieve together. That said, it felt as though as we worked through that plan that there were elements that would benefit from us taking a more systematic approach in a way that would actually help us to achieve our health and care outcomes for the system. So when we're thinking about the outcomes that we want individuals to achieve, such as enjoying independence, feeling connected, having a healthy lifestyle, and planning for the future, we kind of did a self-assessment against ourselves to understand where are the things that we feel as though we could do more together. Section 6 of the paper that we shared with you, those future priorities, were ultimately the elements that we felt as though if we came together and take a more systematic approach across the partners in Staffordshire, we could actually achieve quite a significant amount. So thinking specifically about certain long-term conditions that we know are prevalent across our population, such as dementia, they can have such a detrimental impact when it comes to accessing various services from a kind of acute and statutory sector system. We could actually be taking more of a proactive, community-based approach in order to be as preventative as possible. The same can be said from another element that we felt as though there were certain weaknesses across our pathway were concerning falls prevention. So we identified a gap when it came to that community focus around strength and balance exercise that would actually help individuals to achieve that independence, achieve a healthy lifestyle and feel connected. And the final one was planning for the future. Again, it felt as though sometimes we identify situations at that crisis point and don't always feel as though we have that plan in place at an individual and kind of community level to ensure that we have the foresight to understand what needs to happen when those crisis situations occur. And that's from a variety of perspectives, including financial situations, as well as any kind of care situations that people may find themselves in. So these were the priorities that we wanted to share with you, to have a discussion, to get your feedback on and identify the level of commitment that this board is able to provide in terms of how we deliver that and move it forward. The ultimate aim with this plan is to build resilience as much as we can, resilience amongst ourselves as individuals and as communities, so that if we do experience those situations that may have a negative impact, the stronger that resilience, the quicker we can actually recover from that and move forward in a positive way. So I'd really welcome your thoughts and feedback and to have that discussion about those priorities and discuss how we can, as a system, kind of move forward to deliver them in the future. Thank you.
Yeah, thank you very much, both. Okay, open up for questions or comments from any members of the board. Don't see. Oh, so Baz first and then Claire.
Yeah, thank you for that. That's a really good update. Just wanted to highlight a lot of the times when we do some surveys or ask patient feedback, what we do tend to hear, especially around prevention, is about the falls. And that's a big area that does seem to have the most amount of impact for, and the reasons why most people do end up in either hospital or waiting for an ambulance or something like that. So I just wanted to highlight that, and I know that you've put that in there, so that's really good to see. And if we can support you on any research that we've got about the falls, we will be more than happy to share that as well.
That's wonderful, thank you.
Thank you. So I think it's a really comprehensive piece of work, and I think it's a really useful one as well, something that we probably needed to do for a little while in terms of bringing together all the various bits of work that are happening. And I think it's the right approach, absolutely, in terms of that system level kind of stock take and gap analysis that was done, and then looking at where those opportunities are. I just wonder, it's a bit of a question as well, I suppose, in terms of the partnership. Do you feel at the moment that it's got the right membership and the right sort of gravitas and I suppose, to achieve what it needs to, or does that need a bit of review and maybe support from this board to sort of take it to the next level and fill some of the gaps?
It's in the past, the work that we've done over the last 12 months, I would say the partnership has been really beneficial, so that it's we're as collaborative as possible. I would say moving forward, it would be helpful to understand if there are other members from this group that would be interested in being part of that, so it can just strengthen it as much as possible. So we had a recent meeting where we decided it would make sense for that partnership to continue, but for there also to be a kind of localised element of it when it comes to the delivery of the plan. But we have some representation from this board today, but it would be great to understand if there are any other sort of volunteers that would be interested in being involved.
And just to add to that, I'm just thinking from that locality perspective, there's at least one district that's approached us who want to sort of really take this agenda forward. It would be no surprise. It's one of those districts that has a sort of a higher sort of level of older people, which is South Staffordshire, and they approached us only last week about actually developing a specific sort of summit. So very quickly sort of had a conversation with Suki, who actually covers that patch. So I think I'm not saying it needs to take place elsewhere. What I think our wider partnership can do is support that more local work and bring the right people together, because actually this is going to work at a local level. More we can put those big things in place at a strategic level, but for that real resilience at that local level, some of those more practical things are going to have to take place locally. So I think that's where we may need to sort of think about how we develop this and support other organisations as we move forward.
So, Tilly, a question on that, if I may. Have we gone out to all the districts and boroughs and asked, or is it South Staffordshire who've made the direct approach with you without being approached themselves?
So the simple answer is no, we haven't gone out to every district and asked them. But what does happen is that we've got various people in terms of our own team that are engaged with the districts about different agendas. So South Staffs did approach us. I sit on their partnership board. Their priorities, as you well know, Mark, as I know it's your patch, they're very aware of their population, and they did come back and say, how can we make that agenda that's happening at a Staffordshire level, make it more local. So they have approached us. Having said that, I think if any of the other districts or other locality areas do want to sort of take on that approach, we'd be more than happy to look at how we could facilitate and support that. And there are, I think, what will probably what could potentially move that, and I don't know if there is an item later on the agenda, but certainly with the joint strategic needs assessment, and as we get more sort of emphasis, so more local information, it could just help with those priorities, because you know that should be led by sort of the local needs of each area.
Rachel.
I just want to say thank you to Tilly and Vicky, because this the partnership has been brought together by them, really supported by many members of the ICS. We are very supportive of the priorities and that localised delivery as well. So as much as that group may need to develop into that localised delivery, I think we have a lot of people on there very motivated to support that and move this forward. We can't underestimate the size of the challenge here and how important it will be on health and care if we get this right. So this will be work that we need to keep going at and continually input into, because the ageing population and the impact that will have on health and care is as we all know, is significant. So we will continue to support and engage and input as much as possible within that partnership. So thank you both for everything you've done so far.
Okay. Just before I bring you in, Gareth, the last part of the plan, the bit about planning for the future. Yeah, having personally recently, you know, when I say recently, over the last 5 years or so, gone through similar things with both my parents having passed away. The advantage of having planned early, and particularly that stuff around that financial well-being strategy, personally I think is really helpful. I think it's about being people of a certain age, having conversations with other people of a certain age to make sure those things are in place, and not just think, well, everything will sort itself out at the end, and it will, but sometimes that can create heartache when you've got other things to be thinking about. So really welcome that particular part. Gary?
Thank you, Chair. Really good plan. I think you've done a really good job on pulling this together, because I know those flip charts from those original events had a lot of stuff in them, so getting it really focused I think is really good. I just wanted to ask, and I guess in relation to the priorities around falls and strength and balance, and then some of the stats around emergency admissions, is the relationship with private residential care, is that significant, do you think? And if it is it where you'd want it to be?
Is it the metrics, Gary, that you're referring to that are in the health?
More of a general principle, really, in that a lot of the older people that we're referring to will be resident in residential care homes, and obviously they're managed and run largely in the private sector. So I just wondered what the relationship is like with those sort of places.
So Gary, we have a relationship with those care homes where we contract for care, and some others through our safeguarding responsibilities. I think in reality the practice is probably quite variable, and that includes some care homes who are probably doing too much, as well as a small number are probably doing too little, actually. So older people falling over in care homes is a fact of life. It's going to happen. There are things that they can do to prevent either it happening or the consequence of it happening, and some of them do it really well, others not so well. Equally, there are probably some care homes that are overly restricting people because of the risk of falling over and compromising the quality of life. So there's always that balance to be struck. Equally, there are occasions when people fall over without injury and ambulances are called and they're conveyed to hospital and spend a long time in hospital. And we need to ask ourselves whether that was really necessary. Should we be more positive in our risk-taking and understand that sometimes the best thing to do is probably just to watch and wait somebody because of the harm that's caused by putting them through that protracted journey. So yeah, a lot of good practice that I think we can draw on, but probably more work that we can do.
Just following up on that little point, Gary, Richard, not in Staffordshire County, I would add, but my mum subsequently passed away following a fall in a care home. And I certainly happy that the care home had got the balance right, and I think that's important. I pick up on what Richard said about she was determined never to use any sort of walking aid, however much I tried and the staff there tried. But it would have really restricted her life if they had have started forcing her and making sure she sat down and having somebody watching her all the time. So I certainly think that answer from Richard about that being a balance and getting it right is really, really important at the end of the day.
Yeah, thanks. Just really to reiterate what the Chairman said earlier about the involvement of local authorities and the districts and boroughs, because I do believe they have a big part to play here, and certainly through the representation that we have on this board, I think it's really important that we go back and speak to them, because they will have information and data, and also they'll be wanting to be part of this going forward. Because of an ageing population, most of the districts and boroughs will have some sort of experience of that. So I think it really is important that they can play their part in this by coming to the table and being able to sort of assist in some of the work that you're doing. So I would encourage the engagement, and as I said, through the reps, you might be able to make sure that all those districts and boroughs are brought on and have sight of the plan and can sort of feed back into you if we can, Chair.
Okay, thank you, members. Oh, Chris.
Yeah, thank you. Thank you, Chair. So yeah, just to echo Rachel's comments, the kind of frail elderly population is a real area of priority for us in health circles. So it's great to see the kind of multi-agency work that's going on in this space. And this might be a question as much from my health colleagues as much as anyone else, I think. But the one thing that struck me, and I thought Gary was going to ask the question, and I don't think you quite did, at least as it was formed in my mind, was the relationship between the metrics in Appendix 2, where the rate of hospitalisation for people with dementia is probably the one metric that's going out. But I just didn't quite see the direct correlation then into either the action plan or the priorities. And I suspect it's probably implicit within improved management of dementia, but just unpacking that a little bit to say, well, actually, what does that mean in practice, and then particularly the role for health in that, I think.
Yeah, thank you. I suppose one of the challenges for the plan was which elements of it are that really early primary prevention, which are the elements that are kind of the secondary, and which are the elements that are really the bits that are pushing against our doors in terms of some of the pressures that we're experiencing as a system. So trying to strike that balance was a challenge that I think we haven't mastered yet. But specifically around dementia, I've not been an expert in it, but I've been able to get an understanding of the work that has been going on, and myself and others within public health have started to consider it from a prevention and early intervention perspective, and that's allowed us to have a little bit of an insight into what is happening across the system, and it just felt as though, for a number of reasons, the metric, as you've mentioned, that we've identified as a board, how that then sort of translates in practice for individuals in the population, and how building on those healthy lifestyles is that ultimate kind of prevention element of it. It felt as though we could try to have a stronger impact by doing this together on those different levels, that primary, secondary, tertiary, rather than us potentially doing it separately, which is what it sort of feels like at the moment. So it just felt as though that particular area would really benefit from that systematic approach and just sort of tying the dots together a little bit more so, specifically for dementia, but also from that falls prevention. And the logic around picking those three as well is that they do tie into each other very strongly. So if you have that care planning as well, that can kind of lead into that improved management side of things and that early diagnosis, rather than it being sort of seen as in isolation. I know that there's work happening with colleagues in the ICB around a sort of Staffordshire dementia strategy, and we've already expressed our strong interest in being involved in that, so hopefully that will go some way to sort of achieve or make some traction specifically against that metric, and others as well that we're particularly interested in from a public health perspective.
Andy?
Thank you, Chairman. Just picking up on Councillor Wilcox's comments about getting the message back to districts. Very happy to take back and prioritise the message for whichever districts you think we should be targeting. You've obviously mentioned South Staffordshire, but any others, do let me know. I'm sure with councillor colleagues we can pick them off between ourselves. Thank you.
Yeah, thank you.
Okay, that's fantastic. Rita?
As Tilly said, South Staffordshire, we've got a large ageing population, and our aim is to make those ageing years as healthy as we possibly can, which is why we take this very seriously, which is why we want to be part of the partnership. We had our parish summit last month, and we had one of the speakers specifically aimed at this, and I think we gained a lot of insight and a lot of information from that, and that's where we're going to go forward with it.
And being not a district councillor, but my county patch is in South Staffordshire. That work that they've started doing in South Staffordshire on a three-tier basis, with parishes, the district, and the county. And we had a previous parish summit, I think, didn't we, Tilly? That was all about around the health environment and ageing in particular. And I think we put the challenge out, didn't we, to parish councils about what you're doing in your little community about this type of thing and helping and what can you do around that. So those areas that are parished around the county, maybe that's something that you should also be asking your parishes and working together. And I don't think Rita would mind me saying that the work that we've done on a three-tier basis on the whole, it hasn't always been quick to get off the ground, but I think it's starting now to be really good. And it's not just about getting somebody to fill a pothole. It's about those bigger issues around health and isolation and those type of things in our communities. So, okay, so unless there are, yeah, no problem.
Chair, I don't know if it's worth making everyone aware, but Staffordshire Fire and Rescue Service have had a falls response service up and running for over 12 months now. And we respond across Staffordshire and mobilised by the Unscheduled Care Coordination Centre to non-injury falls. We've attended over 1,000 calls now in the last year, where we've done a large proportion of those pickups where the person's been uninjured. And what we've found is that it's quite difficult to find someone to refer to. That's essentially a near miss where the person's fallen and been uninjured and not had to go to hospital. And again, it's likely to happen in the future again. But what we found is the falls prevention services that we can refer to are a little bit ad hoc across the county. So what would be really useful if there was one falls prevention provision that we could refer into to get people the support they needed.
Yeah, Vicky.
Yeah, thanks, Ian. That's really helpful. The thing that I've sort of learnt is that we do have those, I think there is room for there to be a more kind of standardised approach across the county when it comes to falls provision. But it felt as though there were quite strong pathways once an individual had fallen and they start to sort of come into that system. And what we want to try and do with this is to sort of preempt that, and that strength and balance is the evidence base to show that then that individual's got that resilience to prevent that fall from happening in the first place, and then they kind of feel upskilled to be able to support themselves if they do experience a fall and kind of go down a different route, not necessarily going into services, although it could be that that's what's relevant for that individual. But but I do agree with you in terms of the provision. It seems to be a little bit kind of mixed based on where you live in the county.
And Dave, and if we can make this the last point or question, please. Thank you.
Yeah. We've been doing some work with the ambulance service in the last few weeks, and we've also got a public consultation out. From our feedback from the public, the average wait time for an ambulance, if you have a fall, is between 6 and 16 and a half hours. So these are some of the people that are spending the longest time on the floor. In the last week, West Midlands Ambulance tell us that falls was the fourth highest number of call-outs they had in Staffordshire, followed by mental health at number 5. And also the other comment they've made is with relation to care homes in particular. They said if every care home had a lifting device that enabled them to raise patients up off the floor, a lot of these patients could be sorted without ever needing to call an ambulance in the first place. And some care homes do have them and some don't, but we think that's possibly something that could be raised in the quality forum that goes on in discussions with nursing homes in the county, because, you know, when you hear people telling you that they spent 16 and a half hours in Tamworth lying on the floor waiting for an ambulance when they've got multiple conditions and, you know, the obvious issues that come up like continence and food and medication and so on, all pile up on top of each other. So that's what we found out from the ambulance service and from the public.
Dave, thank you very much. I think they've made a note of that issue, so thank you very much for that. Okay, so I think we've given that item a really good airing, and the first part of the recommendation to consider the health in ageing plan, I think we've done that. So there are two real recommendations, and that's to approve the plan as it's been presented to us, and then to commit support to delivery of those priorities across the partnership. Are we all happy with those two recommendations? I think that I'll take that as an absolute yes, and then we will, before we move on to the next item, it has been remiss of me, and I didn't mention the fact that Mike's predecessor on this board, Councillor Julia Jessel, has stood down as being the portfolio holder for health and care at the county after a long period of time. So on behalf of the board, I'd like just to say a very, very big thank you to Julia for her input, not only to this board, but also as a cabinet member and a colleague of mine for a period of time, and as a long period of time as a councillor. And she's not standing down from the council completely, but probably, I understand, will be doing at the end of the term. So we'll move on to the next item then, which is, the Staffordshire All-Age Carers Strategy. And I think the timing might have been spot on, because there's somebody walked in who's going to come and present that. Lovely. How about that for timing? Okay, if I could ask you to introduce yourselves first, and then we, at your leisure, we'll go in and have the report.
Hello, I'm Jackie Averill. I'm a commissioning officer in the Learning Disability, Autism, Mental Health and Carers team, and the lead for carers services in Staffordshire.
Hi, I'm Julie Sadler-Wright, and I'm one of the children's commissioning team, and I work in the SEND team. And I've been working with Jackie on the all-age carers strategy, bringing the young carers perspective to it. And I've also a carer alongside of my full-time work for my mum who's got Alzheimer's and dementia. So being part of this has really given me a really good insight into how things and questions that we need to ask.
And just before we start, however tempting it is to look at me when you speak, you know, most people wouldn't want to. The problem is with the directional mics, if you turn away, nobody can then hear what you're saying. And as it's being broadcast live, then the broadcast doesn't go out. And this room isn't brilliant for the acoustics. So if we can keep our voices up, it would be really great. Thank you. So over to yourselves.
Thank you. I'll just talk you through the process of how we've developed New Carers strategy, if that's okay. And then if you'd like to ask any questions at the end, that's absolutely fine. I have brought some notes as well, just to prompt me. And can I just mention as well, before I begin, that we have a colleague at the back, Claire Taylor, who's from the Integrated Care Board. Unfortunately, there's not enough room for you at the table, Claire. But please feel free to chip in if that's possible. We've been working on the new carers strategy for some time. It will replace the current carers strategy altogether for carers, and it will be a 5-year strategy, so it runs from 2024 to 2029. It's a joint strategy with the Integrated Care Board, and it's all age. That's a really important point to note. So it covers young carers aged 5 to 17 years old. And in fact, we do have a carer who's aged 4 years old with our current carer service provider at the moment. The project group comprised of commissioners from the Children and Families Directorate, Adult Social Care. John was with us from Public Health, the Integrated Care Board. We have had a change of membership from the Integrated Care Board, and Claire is the representative now. And we also had the service lead from the First Contact team who carries out our carers assessments for us, and that was really important as well, just to have somebody who had that operational perspective on the board. We didn't start from scratch when we started to look at the new strategy from 2024. We based our engagement approach on the 7 current priorities within the existing strategy, as these are still felt to be relevant and universal. We also took into consideration current legislation, national guidance, good practice, and what the data was telling us. When we did look at the data, what the data did tell us, we looked at the census data for 2021. The number of people self-identifying as carers had reduced at that point, but the number of carers who were providing over 50 hours per week care had increased. In Staffordshire, about 82,000 carers overall, 82,000 people identified as a carer overall, and that included approximately 1,600 young carers. Carers UK estimate that the value of the care that those carers give is £2.6 billion a year, which is massively substantial. When we look sort of at our current carer services, we have approximately 2,000 carers on our carers register with our carer support service provider, which is Staffordshire Together for Carers. 2% of adult carers, which feels quite low, and 25% of young carers. So one of the things we feel we need to do is to encourage people to self-identify as a carer so they know what services are available. The data told us that ethnic minority groups in particular are underrepresented in carer support services. Carers are entitled to a one-off direct payment to help with their assessed needs, but less than 1% of carers known to us actually receive one. So that's something we want to look into as well, why that number is so low and what we can do to raise that. The engagement process that lasted for 4 months between August and November last year. So that comprised of survey of adult carers and a survey of families of young carers. We ran a number of focus groups, so we worked with existing carers groups, so coffee and chat groups that we went along to. We also engaged with young carers via the existing carers, young carers activity groups, because we felt it was really important to be able to talk to them within a trusted and established relationship, so that they felt they had the honest, they had that to build on, so they could be honest and open in their feedback to us. And there was a separate group for parent carers as well. So we did set up a couple of focus groups to co-produce outcomes with carers, but that didn't work as well as we'd hoped. So we're going to go back to that after we have completed the strategy and got it through governance. And when we look at how we co-produce the action plan, we're going to make sure that we co-produce at that point. We also, as part of the engagement, we talked to health and social care professionals, mainly first contact staff. We talked to staff in Staffordshire County Council who are also carers, just to find out what their experience is, how they're being supported by policies and by management teams. And they did tell us they felt very, very supported, and there was a great deal of flexibility to enable them to continue in their caring role provided through the County Council. We kept Staffordshire Together for Carers involved throughout, and indeed they supported us to carry out some of the engagement through the process. The ICB rep on the group kept GPs informed via their newsletter. And so in total, we spoke to about 412 carers in total, and that included 20 young carers. And I think one of the good things about the way that we engaged, it allowed us to talk to carers who aren't known to us, who are not in services already, and get their viewpoint. Is there anything you want to add, Julie, at that point?
In terms of the young carers feedback, I worked with Staffordshire Together for Carers to think of the questions that we wanted to ask the children and the young people. And we asked the Staffordshire Together for Carers workers to do that session, and because we felt they had the better relationship rather than me turning up and asking some random questions that we didn't think we would get the information from. So they did it as an activity and sent me lots of sheets of post-its with their answer to the questions, and then I analysed all of that feedback, and we used that within our strategy. And some of the feedback was funny, poignant and quite sad, and that's all helped to shape the strategy and make sure that throughout it really identifies the difference between carers who are adult and carers who are young people.
Thank you. For what adult carers told us are their priorities, they did say that in the main the priorities are still right, but many said they're not feeling the impact of the last 4 years of the strategy. We know we've done a lot of work to implement the strategy, but quite clearly there is a lot that we need to build on. Many carers express their frustration. They told us they don't get a break from caring. They don't have time for themselves. They don't know where to start to find information, advice and guidance, and they don't know about support and services available. It doesn't necessarily mean that those things aren't there. People just simply don't know where to start looking for them. People talked very, very strongly about the negative impact on their health, and of those people that we surveyed, 99% said there was a negative impact on their health of one kind or another. A lot of people talked about how the impact of caring on their social contact, and that they were lonely because of that. We heard that opportunities are being missed to identify and link to support, and to identify carers and link them to support through primary care surgeries and social care professionals as well. Many carers said their role isn't recognised or valued by professionals. That came across really strongly. So we definitely feel that there's a lot we need to do in quite a number of areas. And several carers, well, quite a few carers told us that they were very concerned about what would happen when they can no longer care. So looking at priorities for the next 5 years, they will continue to be in basis what they currently are, so identifying carers clearly that's the foundation for a lot of the work that we need to do, so that we can identify carers and then sort of direct or signpost them to information, advice and guidance, which is another priority. We can support them to stay healthy. Another priority is assessment and support that we provide to carers. We have updated one of the priorities from crisis management to short and longer term planning to reflect that people were telling us we don't know what to do, what will happen when we can no longer care. Life outside caring and recognition and value. So those comprise the 7 priorities for the new strategy. So in terms of the new strategy, what's new? There are quite a number of features which are new. We have a digital support solution is incorporated in there, and we've actually submitted a bid as part of the Accelerating Reform Fund for the digital support solution, and that has been successful. So we will be taking that forward imminently. And we're co-producing a range of affordable carers breaks to take a break from caring. We are planning to introduce mandatory carers awareness training for social care professionals, and we will recommend that for health staff as well. We will explore underrepresentation of minority ethnic groups, and again that forms part of our accelerated reform bid, and we have monies for a post holder to help us with that work. We also already have metrics, quite a number of metrics in place to measure the progress of the implementation plan, but that is actually one of the new things that is new in the new strategy, that we have included within the strategy how we're going to measure progress. So additional work is in progress. We have used, we've had agreement to use underspend from this year to increase capacity for one-to-one support for young carers, and to recruit carers champions in school and primary care surgeries, very much about helping to identify carers and signpost them to information, advice, guidance and support. And we're also looking at how we can improve the range of groups and activities, which is in response to what carers told us during the engagement period. So the next steps are following this board today, the strategy will go to scrutiny meeting on the 18th of March and then to Cabinet on the 20th of March. Once the strategy has been approved and is in place, then we will be looking to co-produce the action plan with effect from April onwards, and as we are planning the approach to this and how we will co-produce it with carers. There are some changes around governance I'd like to make you aware of as well. You might have picked up from the report. The Carers Partnership Board will continue to be responsible for overseeing implementation, and that will, going forward, that will be reporting annually to this board, to the Health and Wellbeing Board, via the Disability and Neurodiversity Partnership Board. Thank you.
Well, thank you very much, both. That's excellent presentation. Right, time for questions, comments, thoughts. Gary?
Thank you, Chair. I should say this is not directed at the officers that have presented. I appreciate it, relatively new into these responsibilities. I think a quick calculation, the engagement is with about 0.5% of all the carers in Staffordshire, and probably mostly ones that are known to the system, given the routes of engagement, and yet some of those stats are pretty horrendous, really. 81% said they don't have enough encouragement and support in their caring role. And so whilst, I mean, I don't disagree with anything that's in the strategy. I think it's, it looks good, it looks like the right thing to do, but I think in my time, 10 years, I think we're on the 3rd strategy, the 3rd support provider, probably the 4th or 5th commissioning team. I kind of wonder why the strategies they don't seem to be making progress.
Can I just respond to the first point? Yes, I agree that as 412 carers is a very small percentage of carers in Staffordshire. However, it does confirm what carers told us through our engagement in the last, when we engaged for the last strategy, and it does reflect the national picture as well of what carers are telling us. So while it is sort of a very small percentage, we know that it's representative of carers' feedback across the board. I think it's probably worth just saying as well, sort of, obviously during the last carers strategy, we did lose 2 years to COVID. And we can see that we have a current carers action plan, so we can see that progress has been made. But I think, yes, what carers are telling us is we need to do further work to feel the impact. So that will be through the action plan that we will be developing, and that, as I say, that will be overseen by the Carers Partnership Board and by this board as well, and it will be against those metrics that we have identified within the strategy.
Yeah, thank you for that, Chair. One of my first papers that I should be taking to Cabinet in a few weeks' time is this paper. And I don't profess to have any real experience in health and care, but in reading the strategy and reading the responses to the consultation, you can't help being moved by what tremendous work all these people do in our communities, looking after families, etc. And I think what is important, just going to your point, Gary, I think what is important that we need to ensure that the action plan is sturdy enough and has got sort of teeth in it so that we can make sure that we do address all the concerns that the carers are sharing with us and that we do take action to address some of those issues and make sure that we do reach out as far as possible to those that we haven't done, just to make sure that we are, wherever possible, making sure that we're reaching those sort of extremities where we're not getting any feedback. But you can't help but be moved by what goes on. And when you talk about the numbers of young carers, we need to make sure with all carers that we are supporting them 100% to make sure that there is support there from us and that we're seen in doing that, because otherwise, as you rightly said, we have another strategy that will, that is there, and then in a few years' time we'll have another strategy. So I think it's really incumbent upon us to make sure that the action plan is robust and actually delivers what we want, because it really is important that we support the carers that do this valuable work for us and they feel valued and recognised, and we need to make sure that we do all we can to make sure that happens. Thank you, Chair.
Phil, anyone else to take? Phil?
Yeah, thank you. I was just wondering, based on the feedback, summarised feedback from the adult carers and young carers, I think 7 or 8 of them say more, and yet we haven't got any more resource to be able to respond to that. So I wondered, in terms of managing expectations, whether there was a way to create a "you said we are going to do" summary, particularly for young people, to make sure that they're really clear as to A, the fact that they've been heard, but also B, within the constraints that obviously you have budget-wise and all the rest of it, that they're clear about what they can expect moving forwards. And something on one page, I think, would be even more ideal, so that it's really clear and simple.
Yes, we are planning to do that. So we're planning to do that, and then we're going to be looking at how we share that with people who have contributed, and more widely whether we do that on Staffordshire County Council website, in our comms. So we are looking at how that's going to be shared with carers across the board who have contributed to the strategy.
In terms of the young carers and the adult carers, when we ask the questions of the young carers, we asked the same questions to the parents of those young carers, and there was a real disparity in how the young carers viewed their situation compared to the parents of the young carers. So one of the questions we asked is, what impact, we didn't use the word impact, does this have on your life? And a lot of the young carers would say, well, I just get on with it. It's part of life. I go and see my friends when I've looked after my brother or my sister or my mum. But then when you ask the same question to the parents, you had a different perspective of the guilt that they felt that their young person was involved in this situation. So when we do go back and talk about what you said, what we did, we will have to word it in a way that that looks at the whole picture of how the young people view their situation compared to how the parents, carers view that young person's situation. And some of the differences when I was reading it were quite, it stopped me in my work to think, well, this young person I just get on with it, yet the parent was looking at it in a very different way.
Dave?
Have you given any thought to support carers get out of hours? I'll give you an example of a lady in Lichfield whose husband has dementia. And this is what she said. On Saturday night when we were watching Strictly Come Dancing in the winter, my husband went off on one. He was sitting there battering his head with his fists. I went upstairs and I burst into tears. I thought, I can't do this anymore. I rang the Samaritans and they were engaged. And that was what she did on a Saturday night when she was struggling for somebody to talk to. And we've since put her in touch with the right people like the out of hours crisis teams, etc., for mental health and stuff. But you know, there's a lot of the week when most agencies are shut, when the carers are still having to get on and do it, and when they have crises out of hours, it's very, very stressful.
I can relate to that because that's what I do outside of my day job, and there are times where you do think, who do I call next, who do I speak to? And I think through this strategy around advice and guidance and worst case scenario advice, hopefully we'll start to address that a bit more. But I concur with what you've said, and it's only as being part of this strategy and the situation for me, I've realised what more I can ask for and who I can go to. And so I think when we were doing this, there was quite a lot of things that we talked about that we were able to really understand and unpick some of the perspectives around it. So yeah, we will try and make sure that that is covered in the advice and guidance and the emergency planning.
Any further questions? No? Okay. In that case then, we have two recommendations then. The board is asked to consider and endorse the Staffordshire's Joint All-Age Carer Strategy 2024 and 2029. Well, the first bit of that, the consider it, I'm sure we've done. So do we have an agreement that we endorse that strategy? I'll take that as a yes. And then B, which was mentioned during the presentation, a move to approve the recommendation that this board has oversight of the strategy implementation through an annual report from the Carers Partnership Board via the Disability and Neurodiversity Partnership Board to this board. Okay, are we all in agreement with that? In that case, that's great. So thank you very much for your presentation. So,
I'm not disagreeing with anything, don't worry, Jackie. I was just going to say it will come every March, this equivalent meeting next year, just to be clear. We'll make sure the terms of reference are updated to reflect that.
Okay, John, that's great. Thank you very much.
Thank you.
Okay, and then we will move on then swiftly to the next item, which is Staffordshire Better Care Fund. Come, Rose. If you could just introduce yourself first, and then in your own time.
Okay, afternoon everybody. I'm Roseanne Carora and I'm a Senior Commissioning Manager at Staffordshire County Council in our Older People team. So just going to give you a brief update on some of the key Better Care Fund updates since I last came to the board in September. So in October last year, we received an additional DFG allocation of around 870,000. Staffordshire Mourn has declined this due to a cumulative underspend. And it's important to note we do have limited information available about activity and expenditure of DFGs, but this is being raised at the Leaders Board, and hopefully I'll be able to update you further when I come back to the board at a later date on that. In terms of Better Care Fund returns, the requirement to complete quarterly returns has recommenced this year after a break during the COVID period. The Q3 report has been submitted in February. As per the delegation of this board, I've briefed Mark on this, and he has signed this off. I've also briefed Councillor Mike on the process as our new cabinet member. The regional BCF lead approached us a couple of months ago to see if Staffordshire and Stoke wanted to explore taking up their support officer of demand and capacity modelling. The ICB were very keen to take them up on this, and the Joint Commissioning Board have agreed this. So the ICB are progressing with this offer, and hopefully again at the next board I'll be able to give you a better update as to how things have progressed with that. In terms of one of the requirements of the Better Care Fund, we do need to have a signed Section 75. So this year's was the first time, to my knowledge, that we've had a 2-year plan. So we've drafted a 2-year Better Care Fund Section 75 agreement, and this has included additional schemes that are listed in the paper that have been agreed at the Joint Commissioning Board so that we can streamline our contracting and monitoring and performance arrangements. So this has been drafted. I think we're just awaiting signatures, so it's very nearly there. In terms of the Adult Social Care Grant, I reported at the September board that the ICB Adult Social Care Discharge Grant allocation that we submitted isn't consistent with the adult population of Staffordshire and Stoke. So, as reported last time, this would mean that in Staffordshire, a shortfall of around £900,000 across the 2 years. So we did request in June last year that the apportionment be reviewed to redress this imbalance, and we have requested an update from the ICB on how discussions with Stoke have progressed on this matter, but I don't have an update on that today unless colleagues from the ICB have an update. And then finally from me, in September, we some good news, we were successful in gaining £1.6 million of additional funding to strengthen urgent and emergency care resilience and performance across the winter. So whilst this wasn't specific to the Better Care Fund, in Staffordshire we've made the decision to include some of these schemes within the Better Care Fund, so add them in. So this will make our contracting, monitoring and payment processes a lot easier. And again, we thought it might be useful at our next update, once the schemes are finished, that we can present some feedback and hopefully some positive outcomes on some of the things that these schemes have delivered. So that was a very brief update from me. Any questions?
Inevitably, I think. So Rose is absolutely right. In fairness, the adult social care discharge grant is paid in 2 grant blocks. There's a grant block that comes into the local authority direct with a defined allocation, and then there's an allocation that comes into the ICB for apportionment to essentially to the local authorities in the ICB area. So there's 42 ICBs in England. Some of them have 1 local authority, some have 2, some 3. So there's no nationally set apportionment methodology in the national guidance that accompanies the grant, other than to say it must be apportioned in a manner that is agreed between the relevant parties. So obviously in this conversation there are 3 parties, Staffordshire, the ICB and Stoke-on-Trent City Council. And so we did receive a request from the County Council in June to review the apportionment methodology so that it was rebased to the adult population as opposed to the general population, which has been the established apportionment mechanism over some time. Inevitably, for us to adjust the Staffordshire balance up, that would mean the Stoke-on-Trent balance would reduce, and I'm sure colleagues will appreciate at the moment that's a very difficult conversation to be having with City Council colleagues. So we're aware of the County Council's request. There is a review, a line-by-line review of all BCF and associated expenditure that's taking place in between ourselves and colleagues at the City Council, but it'd be wrong of me to suggest that it's anything other than a difficult conversation at the time being.
Thank you for that, Chris. So do we have any other questions or points? In which case, no. So, members, if you're happy, there are recommendations there, A to F. I don't intend to read them out. They're all there for people to read if everyone is happy with that. they're all a note as opposed to a specific decision. So unless anybody's got any comments about them, I will take those as recommendations of being noted by this board. Okay, thank you very much for that. Thank you, Rose. Thank you. Item 5 on the agenda, which is the Integrated Care Board Joint Forward Plan. Over to you, Chris.
Okay, so this is a process update. There are some, I think we published a covering report and a slide deck. I wasn't necessarily going to refer to the... okay. So just as I say that I'm presented with a clicker, I feel obliged now. So yeah, this is just a process update, really. So the Joint Forward Plan, by way of reminder, is a 5-year plan. It's one of 3 plans that the ICB is mandated to produce. So alongside the ICP strategy, which colleagues will have directly informed, the Joint Forward Plan, which is essentially the ICB's response to the ICP strategy over a 5-year period, and then an annualised operating plan. As part of that, we are required to produce an annual refresh, and as part of that, we are required to seek the supporting statements from colleagues at the Health and Wellbeing Boards within the ICS geography. So we're having a very similar conversation with colleagues at the Stoke-on-Trent Health and Wellbeing Board. Having said I wasn't going to use the slides, I have just pulled up slide 5 there, which is very difficult to read, I appreciate, but I just thought it usefully showed the link between some of the things we've been talking about today and the Joint Forward Plan. So at the top right-hand side there, I think the last bullet point talks about the Health and Wellbeing Board's priority around healthy ageing, and you can see as we move through the Integrated Care Partnership Strategy and priorities, and then into what we call our portfolios, which is the means by which we coalesce effort and resource around a small number of key themes. You'll see that one of those is I'm looking for end of life, but it's not there. Where is it? Promoting healthy ageing and managing frailty. So there's a direct correlation between the priorities of the Health and Wellbeing Board and the ICB. And indeed, actually, you can go back up to the top left-hand side for the Stoke version and see providing the best end of life, living well into old age, is also a common theme. So the Joint Forward Plan tries to take all those kind of ingredients and consolidate the programmes of change that will distill over the next 5 years or so. So we're into the stage where we're doing the annual refresh. I think we updated colleagues last time with the proposed approach pending the publication of some national guidance that was published later in December 23 and then in more detail January 24. Our assessment is that the guidance offers no material change to the proposal that we outlined in December. So we're continuing with that. And on slides 7 and 8 in the pack, what we've called the straw man, what we're showing in the top orange boxes is the content within the national guidance, and then in the lower boxes how we've interpreted that so that we can both show compliance with national guidance but actually create a plan that is derived from local content that adds value to us as well. So we're not just simply ticking a box in terms of what the ICB is required to do. So that's over slides 7 and 8 as I say there for reference. What we've then done is take all of that working and incorporated that into a first draft that's been shared with a range of partners, and we've got a great deal of feedback already. So some of that is about quantifying the ambition within the plan through the inclusion of metrics. Some of it is just enhancing and making stronger the link to programmes of change such as supportive communities in the local authority. We've been asked to give further thought to how we articulate the link to wider determinants and the links to district and boroughs. We've had feedback from colleagues in the voluntary sector community, which we've acted on, and feedback from other parties that we just need to better articulate the interaction between what we do at system level, what we do at place level, and what we do at integrated neighbourhood level. So all of that work is ongoing. That will continue to iterate over the next few weeks. We're taking the what we hope to be the final draft through to the ICB board on the 21st of March, although I suspect there'll be some feedback from that. We will then produce the consolidated version back to the Chief Exec and Chair of the ICB, and then with permission of this group, we will seek to engage with Councillor Sutton as Chair for the support to the proposed statement that's on the right-hand side there for inclusion in the final document. We do just need to navigate the timings a little, because the national requirement is for us to publish by the end of March, and obviously we're here on the 7th, so we've not got the final document available, so hence us seeking support for delegated sign-off, which is similar to the process we used in 22-23. So I think there is one final slide which just shows the timeline. Again, very, very difficult to see, but yeah, I'll pause there. Happy to take questions and comments, but essentially from a board perspective, we are seeking support to delegate final signature to Councillor Sutton as Chair of the board.
Okay, thank you for that, Chris. Again, questions, thoughts? I'll take that there isn't any then. In that case then, we move straight to the recommendations that are listed there, A to D, and that the board notes the joint forward plan guidance that was published on the 22nd of December of last year and the 17th of January of this year. B, receive and endorse the outline straw man of the addendum to the joint forward plan. C, agree to receive the draft addendum to the joint forward plan virtually. And D, to formally approve the decision to delegate to the chair of this board the sign-off of the joint forward plan for the Health and Wellbeing Board to meet the NHSE timeframes for the beginning of the next financial year. Are we all agreed on that, colleagues? Thank you very much, and thank you for that, Chris. The next item, which is the Health Watch update.
Yeah, thank you for that, Chair. Yeah, today I'll be giving an update. Dave will also be giving an update on things about our key highlights we're picking up as a Health Watch. So I'll start with that, and then we will move on to our ongoing priorities, especially around our deep dives as a second part to this. So some of the key highlights we're picking up at the moment are to do with, so working in partnership on some of these things, and we will, and they are in early stages at the moment. So we hope to bring this back to this board on the updates as and when we pick these up. I know we're due back in around December time. But again, if there's anything sooner, we will pass that back. At the moment, we are working with colleagues within ICB and MPFT around continuing healthcare. What we do know is that one of the biggest challenges facing all systems is to support the care of our frail and elderly and those with long-term conditions. We are going to be working with our partners to look at the patient feedback on the effectiveness of the CHC. I know there is a fairly large spend in Staffordshire. We do believe it's nationally, it's probably the highest compared to other local areas. And as we do find out more information about this, like I said, we will be feeding that back. Secondly, moving on to cross-border. So this is something that does come up often because we do partner with other counties around us. On this occasion, it's to do with mental health services. It's something that's been raised to us, both from residents and from, in this particular occasion, Councillor Paul Harrison. It's something that's come up as an issue for residents who are trying to access mental health services and are struggling, feel that, well, they've been told that they're going to have to travel, for example, from Kinver to Cannock. It's over an hour because the routes aren't, sorry?
3 hours by bus.
Yeah, 3 hours. Yeah, so it's quite a difficult journey, and what makes it really difficult is that there are residents that are trying to seek mental health support. So when you're feeling fairly well, it's tough enough anyway to be maybe on a bus for 3 hours, but this is where the concerns are. Now, we have reached out to MPFT and partners within the ICB. We do know there are some agreements in place for cross-border agreements. That said, they've also noticed there's been a sharp decline in the uptake of that. At the moment, again, early stages, we are trying to investigate whether the GPs are either not referring or whether it's GPs or services across the border that are maybe struggling with influx of numbers and therefore maybe not taking them on. We're not quite sure yet what those reasons are fully, but we are at the moment in the early stages of really trying to understand what's going on, how to support residents to be able to get access easily across border. We are working with West Midlands Ambulance Service. Something that has come up through residents contacting us is something that they will pick up a little bit more further on in a bit more detail. What we do know is that at the moment, in a 12-hour shift, the ambulance services are hitting about 3.2 calls. That used to be 7 to 8 calls, and that's a massive difference, especially in the rural areas. It gets more highlighted in the moorlands, but it won't be unique just to the moorlands. This is what we are picking up at the moment is that the Cat 2 and Cat 3 calls are consistently being missed, and there's a combination of reasons due to demand and handover delays at hospitals. There are about 430 ambulances across the West Midlands, just to be aware of that. We have been speaking to partners. We know that UH&M is where some of the problems are, especially around Royal Stoke Hospital, where it's one of the bottleneck areas. Often we do hear it's about 24 ambulances waiting out there for hours just to hand somebody over before they can go back out to maybe other calls. So that is something that we're working with partners and the ICB to look at how we can improve that. We do know as well, speaking with West Midlands Ambulance Service, they are finding the CRIS services, which is the Community Rapid Intervention Services, very useful in admissions avoidance, and would like to see this extended to 24 hours. And that is because they can really work together to hopefully keep those patients, they can go out to them in the community and keep those patients and give them the support that they can get at home rather than getting into hospital, which can then block up again A&E, etc. We do know that also new mental health ambulances and crews have now been trained up and introduced into the system. And we have been working with West Midlands Ambulance Service to look at maybe doing some visits in the control rooms to see it from that side to help with our deep dive. And again, Dave will pick that up a little bit more in a minute. Again, with patient transport. So the non-agent patient transport is something that has been coming up for a while. It was something we kept bringing up, end of the last year. It's still ongoing. We have fed this back to the ICB. I do attend the systems quality meetings, and we do give a feedback and a report there as well. So they are looking into this. I know they've done a deep dive on this, and we might get an update on that. To look at what those reasons are. Some of the things that we have picked up in terms of the negative feedback has been around the 4 to 6 hours to return patients. So it's quite a long time, and uncertain times as well. They don't know when they're going to be taken back. And again, waiting times post-dialysis. Something one of our patients who reached out to us, who's kind enough to work with other residents out in the community, who has done a really good report that we've anonymised and passed on to the ICB with his consent. And that's been really, really good. One of the examples I remember reading, and it was a really difficult read as well in that sense, there was a 90-year-old woman waiting there for hours after dialysis, and the example given is after dialysis, especially after 4 hours, all you want to do is go home and go sleep, and this person really struggled with that. And again, excessive times on transport, people exhausted, and not always drivers not always aware of the most efficient routes. Another area where we did do a joint interim review at Royal Stoke Maternity Ward here. This was on the 20th of November last year. Most of the feedback was positive that we got from the patients in there. There was 1 or 2 grumbles about the way they were treated, but overall they were fairly good. It's a good report, and that is on our website now for anybody, or if you would like me to forward it on to you, I'm more than happy to do that. However, that said, what we do know is that Staffordshire Stoke-on-Trent has got the second highest neonatal mortality rate in the UK, and that UHNM Neonatal Improvement Group has been re-established to better understand the data and identify areas of poor learning. The Children and Young People's Programme Board has commissioned an infant mortality review, and a steering group has been established to investigate the wider social factors which may impact on neonatal mortality rates. I mean, what we do know is that generally in Stoke-on-Trent, the people in the communities there are using the NHS services at the third highest level in the country as well. There is a full root cause analysis, which is completed for every neonatal death. Also following a CQC visit to UHNM maternity wards in March 2023, a Section 29A notice was issued with further actions, including the final report. The Trust responses to these actions were overseen by the ICB and NHS England. Some of the other things were about giving assurances, and this was about patient safety specialist officer who has been put in place as per the Ockenden report. The freedom to speak up policies across the IC have been refreshed, which we do welcome, and we do think that's one of the most important parts, because often when things don't go right, what patients say is, I wasn't heard, and that often goes for staff as well, being listened to. And again, we've been given assurances by the different trusts as well that they are updated these processes and put them in place. There had recently been successful recruitment campaigns in both UHNM and UHDB to reduce the vacancy rate. When we did our entrant review in 20th November, what we did come across was that they had about 21 vacancies available at the time. It's about 50 staff, and they needed about 71. So we can imagine that must have impacted quite heavily on how they were offering that service. But we do know, having spoken to them, that we're working very hard to get the recruitment numbers up, and that's been making a big good impact on their service. There has been significant improvement in the induction of labour performance over December 23 and January 24. Midwifery vacancies have reduced with further recruitment events planned. The improved staffing position also supports their home birthing services, which is due to recommence from April. Okay, so just before Dave comes in, this is a part of our next 3 deep dives. We'll be looking at 999 ambulance and ambulance calls, and second one will be admissions avoidance, and the third one will be discharges. So I'll hand over to Dave to start with the first deep dive.
Thank you. We're working obviously quite closely with West Midlands Ambulance Service, and we had a meeting with a couple of their directors earlier this week. Starting point really was the ICB's key metric for 23-24 was to reduce category 2 and 3 ambulance calls, which has a knock-on effect right across the system, because all sorts of people have got to do all sorts of things to make that happen. So we started off with, we've initiated a patient experience survey across the county, calling for people's experiences of using the service. We've had 320 odd responses so far, which vary from the ambulance stopped twice on the way to hospital and restarted my heart, and if it wasn't for them I'd be dead and I'm eternally grateful, to I waited 16.5 hours on the floor for somebody to come and pick me up, and everything in between really. Some of the key highlights, I guess, falls comes up time and time again, and talking to the ambulance people on Tuesday this week and the last week, the 6 top reasons for calls were unwell generally, and apparently there's quite a high acuity amongst people they're taking to hospital at the moment. Bleeding, chest pains, number 4 falls, number 5 mental health, and number 6 trauma. So mental health's coming higher than trauma at the moment, which was quite interesting, I thought. We know that MPFT are building a new crisis centre for mental health on the St George's site, which is due to open later in the year, so hopefully that will make a contribution to where some of these mental health crisis patients go. But the big bottleneck is A&E at North Staffs and ambulances sitting outside. In January this year, 2,851 episodes of delayed offloads of ambulances, and the response time to category 3 calls of 43.3 3-4 minutes. In February, it was down to 1,861 delayed, and the response time for Category 2 calls was 35 minutes. So there's a direct correlation between the amount of time the ambulances are sitting outside Stoke and the time it's taken to answer some of these calls. The general view of the public is very complimentary about the paramedics. It's just when you get them, really. I mean, West Midlands ambulance answer calls within 2 seconds, but sometimes you can wait 16 hours for them to come. They are looking at referral alternatives to hospital admission when clinically safe to do so, and they tell us that they only transported 48.5% of the patients to hospital. So there's less going to hospital than being taken. Having said that, we've talked to various members of the public. I was talking to a PCSO the other day who said, oh, sometimes it's quicker just to put them in the car than take them to hospital. And we hear it on the radio all the time. But you talk to the ambulance service and they say the number of times we're waiting for police to turn up. So it's a balance. Everybody's under stress, and demand's very high all over the place, isn't it? But you know, that was some of the feedback we've had. One thing I would like to mention to you, which you may or may not have seen, is the Association of Ambulance Chief Execs have produced, in November last year, produced a vision for NHS ambulance sector in co-designing urgent and emergency care provision. And one of the quite interesting points in there is they said when everybody's having problems recruiting, we don't have any problem recruiting paramedics or training them. And we're already starting to see paramedics being employed in primary care. The ambulance people would suggest that you could rotate them through A&E to help with some of the staffing shortages in A&E, that they are the people that are used to going into houses and assessing people. They've got very sophisticated communication systems that could coordinate more things across the economy. It's an interesting paper with a lot of ideas. I came across it the other day. I happened to join the patient forum of the London Ambulance Service, where the chief exec of the Ambulance Association was going to be talking. But it does make interesting reading, and it's got some useful ideas that might be worth considering as time goes on. I think that's probably as much as I can really say at this stage. I mean, we will move on to do the admissions avoidance and the discharge, but there seemed to be a logical flow through that series, really, and we're intending to do that over the next sort of 12-18 months.
So thank you very much, both. Before I move on for questions and comments, Chris had a greater sort of system approach to those difficulties. I wondered whether this is something that those sort of delays that at hospitals and that the ICB considers in the whole system approach, or is that not? Is that just the acute hospital's responsibility? I'd just like to understand a little bit, if possible.
So yeah, very much. So ICBs, all ICBs in England continue to work with NHS England as the regulator. There is a kind of a nationally set oversight framework for ICBs, which includes in measures around urgent care performance, as you'd reasonably expect. So it is a very frequent and lively topic of debate between both the ICB and NHS England at regional level, but also then between the ICB and all partners in the system, actually, because whilst there are, as Dave and Baz have said, Royal Stoke tends to grab some of the headlines. The challenges around pressure on A&E services is not unique to Royal Stoke, and is actually as much connected to the efficacy of primary, community and discharge processes is about what's going on in the hospital itself. So it is very much an area of focus. I think there's a couple of things that I'd like to say in response to some of the comments, if that's okay. So it is undoubtedly the case that particularly over winter, but other times as well, we do experience sustained pressure on urgent care services, and that can manifest itself in ambulances, ambulance delayed turnovers. We do sometimes see the numbers of ambulances queuing at some of our hospitals much higher than we would like. Not often, I say. I think I would suggest 24, which I think was the number quoted, is probably the more extreme end. Yeah, so we do get there, but it's not the norm. But it is nonetheless, it's higher than we would like. There are two bits that I'd introduced. I think one is that correlation is not necessarily causation. So we've also experienced times where there's been 0 ambulances queuing at Royal Stoke or Queen's Hospital, Burton or County, and WMAS have still experienced increases in the Category 2 wait times. So the reverse is also the case on occasion, which just goes to show it's multifaceted in terms of the challenges. And then just in terms of the long patient waits, there are now new regional protocols. Again, they're not unique to Staffordshire, they're for every system in the region, that where a patient has waited more than 7 hours, there's a set of particular actions that need to take place. Where they've waited more than 8 hours, there's a requirement for that to be escalated to what's called the NHS Gold Command, which is a rota system that both providers and us in the ICB operate. So Rachel and I, for instance, are both members of the Gold Command. And that's to make sure that there is then sufficient executive focus on those incidents, because we shouldn't be having them. And we do need to get to a point where they are very much the exception. And just having that kind of escalatory protocol in place just focuses that attention. So we certainly recognise some of the general pressures that have been shared, but I think there is just a couple of points of balance that might be useful for colleagues to hear.
Chris, thank you very much for that. Any questions on that of our Health Watch colleagues at all? Richard?
Thanks for the report there. Unfortunately, some of that doesn't come as a surprise to us, and our Chief Fire Officer has been very keen on us getting involved and assisting with some of those issues, particularly around the falls response and the long lies. To uninjured fallers, we have a response time of under 40 minutes to get to those people. Some of the challenge, I think, comes from getting those calls through the system and to us. So there's opportunity for some improvement there, I think. We've also recently started a hospital discharge service from the Royal Stoke, which is additional to the current services and different to the traditional drop-and-go service, where we provide a discharge and settle-in service. We started that in December, and to date we've done over 300 discharges from Royal Stoke. So we were very keen to get involved and support, mitigating some of these challenges.
Perhaps we can have a discussion with you outside of the meeting, because it'd be useful to include that in our work, I think. Thank you.
Thank you, Ian. Thank you for those questions. Right, any other questions? Any other thoughts? Okay, thank you. Thank you very much to our Health Watch colleagues for that, which brings us on then to the last item on the agenda, which is the forward plan. And the first thing I'll mention is those amongst you will have noticed that originally we had the annual report from the Director of Public Health on the agenda. It's not. It will be an item on the 8th of June meeting, which is our next meeting, where we will have the Healthy Weight Priority Progress Update along with the Children's Safeguarding Board annual report and a review of the JS&A on that particular date. So just leaves me with saying thank you to everybody that's attended this afternoon, and we'll look forward to seeing you at that date in June.
Thank you, Chair.